Hi, everybody, and welcome to today's webcast brought to you by GEMS. I'm A.J. Heitman, GEMS Editor Emeritus. Today's important and innovative webcast, How EMS Leaders Are Using Mobile Technology to Manage the COVID-19 Crisis and Beyond, is sponsored by Pulsara. Pulsara is a mobile first healthcare communications platform that connects teams across organizations. And what makes Pulsara unique is its ability to enable dynamic network communications for any illness or injury, as you'll see today. With Pulsara, clinicians can add a new organization, team, or specialist to any patient event, dynamically building a care team even as the patient condition and location is constantly evolving. You simply create a dedicated patient channel, build the team, and then communicate using audio, live video, instant messaging, data, images, and key benchmarks, the hallmark of what we're going to talk about today. Studies report an average decreased treatment time of nearly 30% when using Pulsara. It's truly an evidence-based standard of care. And for more information, obviously, you can go to www.pulsara.com/EMS. I want to do a little housekeeping. This event is both live and interactive, so you can ask questions at any time by typing in the Ask a Question box in the presentation window on the left side of your screen. If you have any technical difficulties, please alert us through the Ask a Question box, and a member of our support team will work with you and correct it right away. You're going to get a certificate of attendance for being on here today, but to receive it, you must stay until the event ends, and it'll be triggered when you see the congratulations screen. That's how it's triggered, and you'll get an email for a link to your certificate. The attendees have graciously offered us a PDF that you'll be able to get at the end of this program, and also a case study called Improving COVID Response Together. That's going to be in the Event Resources section. Now, if you're running any pop-up blocking software, please disable it now to view the webcast. In addition, it's recommended that you close down all other applications for better performance. For your convenience, this presentation will be available on demand within 24 hours of the live event. A reminder email message will be sent to all registrants with a link to the archive. It's also going to be accessible from our homepage at gems.com. Now it gives me great pleasure to introduce today's panel of speakers. Leading off, and the person who will lead the show is Chris Call, Chief Marketing Officer at Pulsara. He will then introduce Stein Bronski and Dr. Matthew Angelitis from Colorado Springs area. He'll also bring in Chris Lester, Commander Homeland Security and Emergency Management for Austin Travis County, and John Gonzalez, who's Commander of Clinical Practices for Williamson County, Texas. To start off today's outstanding webcast, I'll now ask my friend and EMS colleague, Chris Call, to take over.
Thanks, AJ. And before we even start, let me begin by just thanking everybody who's both attending and your colleagues and partners, both in the healthcare world as well as the public safety world, those who are on the front lines. It's been an unprecedented and scary time. Let's start out with a patient's journey. This patient journey isn't real in today's world, as in right now in the midst of COVID, but it would have been the real journey not even 4 or 5 weeks ago. A patient thinks they're experiencing COVID-19 symptoms and doesn't know where to seek care. So they drive to an urgent care facility. That clinician doesn't have the resources to treat the patient in transfer center at the hospital, who tells them to call 911. EMS shows up, gets the ambulance, transfers the patient using their proper PPE. They get the information. They give a radio report to the hospital. They get to the hospital. There's 30, 45 minutes waiting to get the patient to be seen. The family or the patient's finally transferred to a room where the nurse and the physician assistant takes a quick report. Then the patient's rapidly assessed and is determined to be stable enough to head back home. And you see, as an EMS provider, the patient getting into their private vehicle and leaving before you've fully decontaminated your ambulance. And while there's nothing wrong with this, what it shows and showcases is the problem with our system in that we transport all patients to the hospital, even if they don't necessarily need to be transported to the hospital, and or we use PPE when we had a lack of PPE, when we didn't need to use PPE, and there were other opportunities for us to be efficient and better take care of our patients and be a patient advocate. That's what we're talking about today, is how do we manage and appropriately treat our patients today, and then, more importantly, how we're going to treat and manage our patients tomorrow and in the future. As a disclosure for myself personally, I am the Chief Marketing Officer for Pulsara, which this webcast is sponsored by. And I'm also a critical care flight paramedic, spent the last 26 years in the EMS world. The purpose of Pulsara is to improve the lives of patients and caregivers through innovative communication. If you haven't heard about Pulsara before, we are a mobile-first platform that allows you to dynamically connect the right people to the right team for the right patient with the right resources at the right time. But let's take a look at what we've done in the past. It's the telephone game. We've had to connect from silo to silo to silo. So it was easy for first responders, maybe via radio, to talk to the paramedics that are responding to the transport ambulance. EMS may have used a cell phone or a handheld radio. We call them walkie-talkies back in the day, CBs. And we would radio report to the hospital, to a person who may or may not be the ultimate individual taking care of the patient. And then if they needed a specialty level of care, then the hospital would page with those pagers out to the group for a STEMI or stroke or whatever critical care team we needed. If that hospital needed to be transferred or that patient needed to be transferred to another facility, it would be a number of phone calls and back and forth pages and faxes in order to get that patient ready to be transferred, and then the whole system starts again. I talked to a neurologist in Swedish Medical Center out of the Seattle area who said on average for stroke patients, she makes almost 17 phone calls on average before she sees her patient. What Pulsara does is we streamline that. We streamline it for the simplest of EMS transports to the most complicated world pandemics. And we build a patient channel. We open up that patient channel. You hear some of those terms being talked about today. Open up that patient channel, and then we dynamically add on the fly whoever we need to add to that patient channel to communicate in real time about what's the best course for this patient. So instead of all those silos, they're eliminated. And instead, there's one united care team that's able to communicate about the patient through their entire patient journey. But what about COVID-19? With Pulsara, there's been a number of interactions that we've been able to assist with across the nation. The first one is mitigating the patient surge by allowing the clinicians that are at that bedside, maybe in the patient's home or at a clinic or at a nursing home, be able to identify what's the patient's acute needs at this moment. They may or may not have to go to the hospital, or if they go to the hospital, maybe it's not the emergency room and it's an alternative destination. Or it's limiting transfers for the clinically appropriate cases. It wasn't that long ago that all patients from critical access or smaller facilities were being transferred to larger facilities. And now that simply isn't the case. Overcrowding major hospital systems is no longer appropriate, and we should be limiting our transport of patients to the hospital for only those who absolutely need to be at that specialty care. The next one is limiting our clinician and patient exposure. If we know that's a potential COVID-19 patient or they're exhibiting those flu-like signs and symptoms that get us to think down that disease pathway, we know that and we can don PPE or even use telemedicine in EMS, which while we've talked about it for decades, hasn't been a common practice until now. The next one is limiting repeat clinician exposure and conserving PPE. We've seen this across the nation in hospitals where now the specialist does not need to go into the room. They can use telemedicine, or they can connect from public health back to the patient directly in their home using telemedicine and not using PPE or unnecessary exposure. And of course, the last reason is to secure outpatient medical isolation. That patient that's at home can connect with the provider of their choice when they need to, based on what the clinician needs to talk to them about. Maybe it's public health initiating that call and talking to that patient once a day to check in. Before we get started, what this presentation is not. It's not a roundtable discussion on the latest science on COVID-19. It's not about the medical care. It's not about any of the science behind this pandemic. What it is about tangible case studies and real life experiences from 3 different areas across the nation on how they're managing COVID-19, and more importantly, what lessons they're learning to manage their EMS system going forward. So with that, we're going to start with Colorado Springs. In the Colorado Springs area, we have 2 medical directors with us today. Dr. Stein-Bronsky is a good friend of mine. Dr. Bronsky began his EMS journey as an EMT in 1991. He attended medical school at Vanderbilt University in Nashville, Tennessee, followed by his emergency medicine residency and EMS fellowship at Virginia Commonwealth University in Richmond, Virginia. He has over 12 years of post-fellowship EMS medical direction experience, including medical direction for both air and ground EMS services. He is currently the Chief Medical Director for the Colorado Springs Fire Department, the El Paso County AMR Ambulance Service, and the El Paso Teller County 911 Authority. In addition, Dr. Bronsky is a member of the Eagles Consortium. With him is Dr. Matthew Angelitis. Dr. Matt is a board-certified emergency physician for UC Health at Memorial Central, Memorial North, Pikes Peak Regional Hospital, and Grandview Hospital in Colorado Springs. Dr. Angelitis is the co-medical director for Colorado Springs Fire Department and AMR. He's also the EMS County or El Paso County EMS medical director and the co-medical director for the Plains to Peaks RETAC and the UC Health EMS medical director. He's been participating in the development, implementation, training, education, and quality assurance for pre-hospital providers across the Plains to Peaks region. Welcome, guys.
Thank you for that very kind introduction, Chris. This is Matt Angelitis. I think I would start with a little context. Dr. Bronsky and I live in Colorado Springs, Colorado. It's the other city in Colorado besides Denver. We're currently in El Paso County, which is roughly 650,000 residents. The city itself, city proper, is 470,000 residents. And that is healthcare shared amongst 5 major hospitals across 3 hospital systems, Children's Hospital and 2 others. And we manage about 85,000 911 calls a year. So just a little context for the city that we're living in.
Yeah, so we have been using mobile technology for a few years now. One of the mobile technologies that we do use is EM Resources. I'm sure a lot of people listening in to this webinar are familiar with EM Resources. Typically, historically, it's used for hospital-to-hospital communication for bed status information, and also for MCIs to figure out and coordinate what beds are available in hospitals. We took this existing EM resource system and repurposed it to show our field crews, EMS field crews, real-time information on service line ability in the hospitals. And so on this screen, you'll see on the right side, there's a screenshot that says status. That just is a screenshot of what a crew member or a supervisor in the field can see when they are in EM resources on their mobile device. and they can look at each individual hospital and see all of the different service lines and know which one is immediately available and which one is not available, so that we can help direct traffic. And that is something that we plan to use and actually make even more robust into the future.
So guys, the second piece of mobile technology that we are heavily leveraging in our community is the Pulsara pre-hospital communication system, which Chris already introduced to you, the basic nuts and bolts. In our community, we implemented Pulsara approximately 4 years ago, primarily to initiate communication channels for a patient with regards to STEMI, ST elevation MIs, and stroke alerts. So in real time in our city and in our region, an EMS provider is able to activate an ST elevation MI alert from the field, and that communication from Pulsara simultaneously sends the EKG, patient's vitals, age, meds, risk factors to the hospital system that they are transporting the patient to, so that the ER physician, a charge nurse, the cardiac catheterization lab team, as well as the interventional cardiologists are all aware of this patient's location within the city and expected time of arrival and their current condition. We have started under COVID-19 to leverage Pulsara in different ways within our community, and we're expanding its use across multiple other avenues such as trauma as well.
So speaking about Pulsara use in the existing pandemic, when COVID-19 hit our community, we immediately recognized that our vision of needing to have immediate telemedicine capability from the crews in the field to the medical directors was an immediate necessity. It wasn't something we could wait a long time for. And the logical choice was to use Pulsara in an expanded way, because everybody already uses it. Every EMS provider has it. They're used to using it for the EMS to hospital communication. And using the existing platform, we could also flex it to start telemedicine consults directly from providers to medical directors. And that could help us within the pandemic crisis to use medical directors when necessary to figure out if people should be transported. Matt will talk a little bit about that in just a minute. Another thing that we recognized was that we could use an expansion on Pulsara to use it for telemedicine consult between a provider and a patient directly, and the EMS provider wouldn't necessarily have to be present with the patient. And we'll talk about more of these. The main thing here is that we wanted a product that we didn't just start up because of the pandemic. We wanted to use an existing product that we knew worked well, that could flex into and out of pandemic situations.
Yeah, I think that's great. What I'd like to do now is kind of give you guys some real-time case examples. And the first thing I have to do is sort of review one of our pre-hospital algorithms. So we initiated a non-transport algorithm for potential coronavirus patients under the idea that not every person experiencing coronavirus symptoms would best be served by being transferred to an emergency department. Obviously, that utilizes a lot of PPE. It exposes our pre-hospital healthcare providers and emergency room staffs unnecessarily. And so we utilize CDC and World Health Organization information, and we developed the algorithm that you see on your screen. Essentially, patients are walked through two boxes on the left-hand side of the screen. We have a set of objective criteria. Those are things that would obviously cue the provider into knowing the patient has to go to an emergency room, like abnormal vital signs. And then box B, which is sort of our more subjective criteria or risk factors. These are things that we know result in worse outcomes for COVID patients. And what I would like to do is just walk you through a case of a very young lady named Lois, a 78-year-old female, who called our 911 for evaluation of cough and shortness of breath. Our EMS providers arrived and they identified that Lois had normal vital signs, but that she is an elderly female, 78, which places her at higher risk in the setting of coronavirus. If you follow our algorithm, that puts us in that middle category. She's negative for box A, but positive for box B. This then guides our EMS teams to initiate alternate avenues of access to healthcare. The first one on the list is to initiate a telemedicine consult. Next slide. So what you're going to see now on your screen is on the right side there, you have an EMS provider wearing a PPE, a mask, and in the top right corner, you have Dr. Bronski sitting on his couch at home. And what we've done is this provider has activated a Pulsara case for Lois, which then pings our medical direction command team. So Dr. Bronski is on call for the day, and he gets a notification on his phone that our EMS crews have a patient they'd like to discuss with him. Dr. Bronski is able to click into the patient, initiate the teleconsult that you're seeing on your screen there, and in real time, he takes a history, discusses the issues with the patient, is able to look at her in real time, and even direct the EMS providers to perform certain tasks. For example, listen to their lungs again or repeat a set of vital signs.
And through that, the EMS direction team can help providers figure out who may need to be transported, who can stay on scene. Another way that we are leveraging Pulsara now is to use what they call Pulsara Patient, which is a platform that gives us the ability to push an invitation to a patient directly from a provider. And that provider could be an EMS crew, it could be a physician, it could be whatever provider needs to get in contact with that patient. And the patient can then open up the portal and we can have discussions back and forth. I'll give you just a very brief example. We have a patient here in town, it's a child that has a really bad seizure disorder. And on top of that, unfortunately, has some airway and respiratory issues also. So they're at high risk for developing some airway compromise when they have seizures. And so historically, every time the child has a seizure, they call 911 just for backup on this child's airway if needed. Well, right now, every time we encounter this patient, we have to use PPE, we have exposures because somebody in the house is COVID positive, and we want to try to avoid that if we can. And so we push an invite to the family who then can speak to a provider that's sitting outside of their house, and they're staged and waiting, and if the child resolves and doesn't need any airway management, then we can communicate that directly from the family to the EMS providers, and then they can leave, and we have not wasted PPE, we have not exposed people unnecessarily. The last thing I'd like to mention is that the Pulsara Patient also gives us the capability of following up with patients. So if we run on a patient that's a COVID patient like Matt was talking about, but has been left at home, then the next day we could ping them again and talk to them and video conference with them. And so all in all, Pulsara has been a tremendous advancement in our capabilities to interact with the patient population during the COVID crisis. And there we'll stop and hear about other people's.
Yeah, Dr. Matt, Dr. Stein, that was fantastic. Thank you. As we move through here, there are a handful of questions, and during this transition time, I will hit a few of them as we move into Austin. There's a handful of questions asking about secure, and I do think that secure telemedicine is critically important. I'm not sure if people are asking about Pulsara in particular, but yes, Pulsara is HIPAA compliant. It is secure. It's encrypted at both ends and at rest during the entire patient process. We also do entire vetting with the hospital systems with their IT group prior to implementation. And then as we walk through this, another question was asked about, does Pulsara access the e-medical records and how does that whole thing work? And We do have integrations, both the ability for EPCR integration as well as EHR. And more importantly, at this moment, as you'll see in these following case scenarios, and what Dr. Matt and Dr. Stein just said, is that this is about real-time communication. So instead of pagers, fax machines, and answering services, we're able to use mobile medicine to take care of the patient right now with those signs and symptoms. And some of these other questions will be answered as we get into these next case scenarios. So let's jump into Austin Travis County with Commander Chris Lester. Chris is the Commander of Homeland Security and Emergency Management for Austin Travis County EMS. Chris Lester is a nationally registered paramedic and has been involved in EMS for the past 17 years. He's currently a commander with Austin Travis County EMS and is assigned to a field operations district that is over Homeland Security and Emergency Management. Thanks for joining us, Chris.
Thank you, Chris, for having me. Thank you for that wonderful introduction. Little backstory on Austin Travis County EMS, a little demographic information. We're located in Central Texas. We're the City of Austin's third public safety agency. We have a response area of about 1,039 square miles, serving a population of around 2.2 million, and run about 139,000 calls annually. We manage that with 43 on-duty ambulances and 9 peak load units as well, and also 6 district commanders. So it's going to go across some of the things we're using mobilely to help manage this crisis of COVID-19. As you'll see, we use several different platforms and for different reasons, but I'll touch on each one of those independently. At the beginning of this, we started what's called the COVID Clinical Consult Line, or CCL, or 3CL. We love acronyms around here, so it kind of goes by all of them. This group is composed of field providers who are currently assigned to the Medical Operations Center and also Austin Public Health. These providers hold a credential that provides them the ability to initiate paramedic-initiated non-transports. The overall goal being to keep COVID patients with mild symptoms at home doing self-care and utilizing other avenues of medical evaluation and treatment, like telemedicine, their PCP, walk-in clinics, etc., instead of being transported to the ED. This has many benefits. One major benefit for us is keeping the exposure risk of our providers down to a minimum to help reduce the risk and spread of infection. Initially, this group was stationed at Austin Public Health in a little conference room, but we could quickly see that that location was not going to be able to uphold the amount of call volume that we would be receiving related to COVID-19. So we moved down to our communication center, where our call takers dispatch 911 calls. This gave us the ability to use the technology that our dispatchers use, and gave us that technology as well for dispatch, as well as some extra computer resources for risk stratification of public safety personnel that are exposed to COVID-19. Using this, these folks have been able to reduce the amount of ambulances sent to COVID-19 type calls by roughly about 30%. The folks that fall in these 30% are assisted with telemed options, walk-in clinics, information how to get tested, etc. We're using a platform called Apricot Social Solutions to capture all the data from the 911 calls we're screening, and then also the public safety risk stratification calls that we receive from other public safety folks. This enables us to get the who, when, what, and where of each contact, and also allows us to quickly see if somebody's called more than one time, how they've been assisted up to that point, and if what we have done is working for them. The hope is that after this COVID-19 crisis is over, the data that we're able to pull from the system will help support the fact that we need something like this to continue to be in our system. One of the new features that we're using in relation to mobile technology is Pulsara. We started using this at the beginning of the COVID response. since we started using it, it's shown to be very valuable to us regarding information, providing information to responding crews before they arrive, during scene care, and also transport. It also allows us to pass this information on to the hospital so they can pre-register the patient and also decide who needs to be there upon arrival based on the information provided to them in the app. We've also been able to use the video conferencing feature a few times. We've used it to initiate some paramedic-initiated non-transports where we just needed more information from what we were getting over the phone. We could utilize the video feature of pushing it to the patient, and we could actually see the situation they're in and actually how they look at this present moment. It's also come in handy a few times with some of our crews being on patients, on COVID patients that have multiple other issues going on as well. And the crews have been able to video conference one of our on-call medical directors. That's been able to give that physician an opportunity to see exactly what situation the paramedics are dealing with at that time, and which allows them to give the best information available to provide the most appropriate care for that patient at that time. Currently, we're looking into expanding the role a little bit, using Pulsara to one of our ISOFAC facilities. These facilities hold PUIs that are unable to self-isolate on their own. And utilizing Pulsara in this facility, we're able to push this to each PUI in the facility, and providers on the floor taking care of them are able to FaceTime with them instead of donning and doffing PPE and going through that process of donning and doffing just to get simple things like temp checks and things like that. It also provides the ability to log the contacts in there with vital signs and everything. So if something does happen and the patient does need to be transported to the hospital for some reason, all that information can be pressed to the receiving hospital so they can see what's been going on with the patient since they have been in the isolation facility. With the start of this as well, having such a large population, we knew testing was going to be an issue both from public safety and critical infrastructure standpoint as well as the public. So the city itself came up with a open enrollment form. This link has gone through several changes, but the goal has always remained the same, which was to provide a quick way for people to get enrolled for drive-through testing for COVID. It gathers some demographic data as to which populations are utilizing the enrollment form, and if there are public safety, critical infrastructure, and also the symptoms they are currently experiencing. This has been pushed out to the general public recently as well to make it easier for them to enroll as well. The last bit that we're using to respond to this pandemic is EM Resource. We've been using EM Resource for a while in our system. This allows the crews to look at the status of a hospital, see how busy they are, and what resources are available at that facility. All this from a mobile device. This additional information helps the crews determine the most appropriate transport destination based upon clinical findings and the crew's differential diagnosis. Currently for the COVID response, the hospitals are updating the availability of vents, ICU beds, ED beds, et cetera, for every 12 hours. If the hospital systems become inundated with COVID patients, they will be updating the EM Resource more frequently, which allow patient navigation personnel and the Medical Operations Center to help coordinate transportation for the EMS systems in the region for the most appropriate facility, which that bit of technology marries pretty well with Pulsara of trying to get the patients to the right resources if they do need to be transported. And that's about wraps up about what we're doing with mobile technology here in Austin Chavez County.
Great. Thanks, Commander Lester. This is amazing stuff. And you guys really have set the standard of saying, hey, let's get a hold of these patients early. Let's bring in dispatch early. Let's actually help provide resources to update in real time this patient care. And let's notify the hospital early, and then they can be part of this process. And both innovative and forward-thinking in a new world we live in. As we transition over, Yeah, thanks, Chris Lester. Let's see, as we transition in over to Williamson County, I was going to answer 2 more questions, and they're about cell cover cell service or using in a helicopter. And I think aviation overall, what we're seeing is EMS services are following their local best practices, protocols, procedures of when they can or cannot use mobile technology or cell phone technology in their aircraft, and typically alerting the hospital or communicating on scene or prior to liftoff in the areas that they can't discuss or use, cell phone coverage in their aircraft. And then the second question is, what about rural areas? What about cell coverage? What about difficulties in contacting? And it's a great question. It's a valid question. And the quick answer is, you're right. If there's not connectivity, we can't do any communicating, right? And in some places, radio communication may be, and repeaters may be our only opportunity. And yet what we're seeing out there is a number of technologies come out that have greatly increased the rural broadband coverage. The first one, I would be remiss if I didn't bring up FirstNet, which is a dedicated broadband platform for us, public safety, that gives us both priority and preemption, which means it allows us to have dedicated bandwidth with an agreement to really have increased coverage across the entire nation. You have areas where it's very congested and there's buildings and it's very urban and cell coverage is terrible. And you also have rural areas where there isn't any coverage or cell towers and your mobile phone usage is terrible. And so FirstNet, in partnership with AT&T, is doing a great job of working through that, especially in the first 5 years of that contract, to get as much coverage up and going as they can. And then there's a number of technologies out there. The first one that comes to mind is Alario. Alario allows you, it's basically a high-end modem router that's small enough to be part of your stuff you can carry into a house. It's mobile, and it puts in a number of SIM cards in there. So you could have a FirstNet SIM card, Verizon or AT&T SIM card, and a T-Mobile SIM card, for example. And then it automatically swaps back and forth between whatever's the best coverage at the time, and it's seamless to the end provider. All right, Williamson County. Let's walk into this with Commander John Gonzalez. John is the commander of clinical practice for Williamson County EMS in Texas. He's been with Williamson County EMS for the past 15 years, and prior to that was a clinical manager for the multi-specialty clinic in Austin, Texas. He served as a medic in the United States Army and holds a BA Associate's degree in the Emergency Management Administration from West Texas A&M University. Thanks for joining us, John.
Thank you, Chris, and thank you to AJ and JEMS for hosting this event. Before I get started, I'd like to give a shout out to our women and men of Williamson County EMS. They've been phenomenal during this entire event, especially with the rollout of Pulsara. They did a really good job at adapting to all the change. I'd also like to thank Captains Matt Biasotti and Captain Dan Cohen. They've been a huge help in rolling out Pulsara and working and making sure that this is a successful program for us. So a little bit about Williamson County EMS. We're located in Central Texas, just north and adjacent to the city of Austin in Travis County. We have a population of over 600,000 people, and we cover a geographic area of roughly 1,100 square miles. We have an annual call volume of approximately 30,000 calls per year, and we have 15 different first responder organizations that we work with in our county. We have 19 MICU capable units running dual paramedic crews. We have 3 regional commanders of response Tahoes, and then we have 1 standalone response Tahoe in the far northwest corner of the county. As far as Pulsara goes, we introduced Pulsara about the 3rd week of March. We were originally set up under the Austin EMS MOC, Medical Operations Center, and quickly realized that we would probably need to expand its use of Pulsara, and so we decided to create our own MOC. As we prepared for our large SARS-CoV-2 patient load, we wanted to have the capability to load balance hospitals in our county, as well as give the crews a lifeline should they have questions regarding exposure or questions related to transport, no transport. We also saw an opportunity to expand Pulsara into our community health paramedicine program, as well as to our Williamson County and City Health District, so that they can monitor patients that didn't necessarily need to be admitted to a hospital and who were self-isolating. We could check on them using Pulsara. Sorry, I wasn't clicking my slides here. So again, there's our staff, shout out to them. Here's our Pulsara workflow. So when we introduced Pulsara, we wanted to keep it as simple as possible. So one of the things we did is we kind of streamlined how we did this. And so the setup you see here is the EMS crew activates Pulsara early on. And the reason that we asked them to activate early on is so that that channel is available once they arrive on scene. They receive information from dispatch. We call it a PPE alert. It's essentially an ILI, flu-like illness type patient. They activate that channel. We receive it here at the mock using some pre-created text messages, so we don't have to type. We can actually answer a call within about 3 seconds. We push out a message that reads, the mock is on and monitoring. That call is then monitored. We also use CAD to track our crews. We also look at notes in CAD as they're being updated. And then once the crew makes scene, they assess the patient and enter information into that Pulsara app. So the process we have here allows us to push this Pulsara call to the hospital. We can also loop in the Williamson County and City Health District if needed. And then we also have Dr. Jarvis, our medical director, looped in as a team member as well. So if a crew has some questions regarding whether the patient needs to be transported or not, we can certainly loop Dr. Jarvis in and help the crews make a decision. So far we've used Pulsara pretty effectively. Someone asked a question about rural areas. We do have some pretty rural areas in Williamson County. Pulsara has worked pretty well in those areas as well. We've had some video connectivity issues, but voice has always worked really, really well as well. So again, we're able to use it, and we use it pretty often. What you see on your screen here, this is a communication that I had with one of our medic units, and this was a field crew that had a patient who had been seen at a particular hospital about a week or so ago, had a simple pneumothorax for which she was treated, and then activated 911 because she was having difficulty breathing, and said that she felt like she did when she had her pneumothorax about a week ago, but now was complaining of a cough and a fever as well. So with that information, it was pushed to the crew via CAD. They alerted using Pulsara, made scene in full PPE, assessed the patient, and decided to transport. The patient was requesting a particular hospital that was not considered a COVID receiving facility because they had a NICU within their facility and were trying to minimize exposure. So on the screen, you can see the communication that occurred. They said they were transporting to a particular hospital. I advised them that that hospital was not a COVID receiving facility secondary to the NICU. They again said patient requests that facility, and then used one of their pre-made text messages, as you can see on the screen there. It says request phone call from the mock. So we created several of these messages for the crews so they don't have to free type, especially with gloved fingers on. They can just have a list of pre-made requests or questions or whatever in Pulsara. They can just pick from a drop down and hit send, and we get it right away. So this one was please request call from the mock, and then they qualified that with patient requesting transport to X facility. So in the interim, I sent a text message to one of our EMS liaisons who did state that that facility would accept the patient. However, if the patient did test positive for COVID, they would transfer the patient to a different facility. I did call the crew. I was able to be placed on speakerphone. I did have a communication or a discussion with the patient, gave her the information that she can make an informed decision on her transport and her care. She did, again, continue to request that facility, and the crew did transport her and honor her wishes. So, again, that's just one example of how we've used Pulsara, and it's been very effective. Our medical director, Dr. Jarvis, is very involved in our system. and we contact Dr. Jarvis for all of our online medical control. So inside our scope of care document, there are certain procedures and such that require online medical control, and Dr. Jarvis is who answers those. He is also available for all of our in-field termination and resuscitation, and so Pulsara is being used for that as well. So we have asked our crews for any online medical control to use Pulsara to contact Dr. Jarvis, and the way we have our Pulsara app set up is Dr. Jarvis is a team member that we can loop him in anytime the crew requests him. And again, we have a pre-made text message that says, need Dr. Jarvis for OLMC, online medical control /TOR. As soon as we see that come across, we loop Dr. Jarvis in, and he immediately initiates either a video call or a voice call to the crew using Pulsara. And again, the reason we do that is because it's all recorded. We can go back after the fact and look at all the communication that occurred between us, the crew in the hospital, Dr. Jarvis and the crew, and so forth, as well as any images that are taken using the Pulsara app. What you see on your screen here is an image that was taken using the Pulsara app. It is of the screen showing, the rhythm, heart rate, pulse oxygen, tidal blood pressure. They also took a picture of a 12-lead EKG. And so when they were on scene with this patient, this was a patient who was exhibiting a low-grade fever, did not have a cough, but had been exposed to a known COVID-19 patient. Activated 911, actually a family activated 911 for the patient, and wasn't sure if she needed to be transported to the hospital or not. The crew, in talking with the patient, decided to loop Dr. Jarvis in for some additional support, if you will. And Dr. Jarvis was able to view the 12-lead EKG, the cardiac monitor, and contacted the crew, and they were able to work through it. The patient ultimately refused transport, but we did have the ability to loop Dr. Jarvis in. We did ask the patient if she would be willing to accept the Pulsara patient app, which I believe she did, and then that way we could reach back out to her should we need to. Like I mentioned, we also use Pulsara for all of our field terminations. And so the process that we had before Pulsara was available in our system is our field crew would contact our dispatch communications center. They would then call Dr. Jarvis, and then they would patch the two together. And that was about a 3 to 5 minute process in some cases, and sometimes the calls were dropped or disconnected. So Pulsara has come in. So when a crew is on a cardiac arrest call, when it gets time to reach out to Dr. Jarvis for a termination, they can activate a channel, they enter cardiac arrest into the description, or they use a quick drop-down pick from the pick list on the text messages saying they need Dr. Jarvis for a tour. We loop Dr. Jarvis into the call. He then immediately calls the crew. One of the things that Dr. Jarvis has said is that surveying the scene, getting the crew to pan the scene so he can get an idea of what's going on, helps him make a decision as to whether they need to continue or if everything they've done has been done and it's now a futile arrest. So he does use it extensively. He does like talking with the crews. This is just one of the things that we use in our system, Pulsara. We also use the resource. We use our CAD quite a bit, but we're really liking what we're seeing with Pulsara, and like I've said before, we're looking at expanding it into our community health paramedicine program. They've been very interested in it. We're using it in our Williamson County and Cities Health District to track patients and to reach out to patients, and we have some other plans for it moving forward. But so far, it's been a good change. Just like with anything, it's a new technology. Crews are going to ask questions initially, and because it's new, especially during a pandemic, things can get a little frustrating for the crews. But they've done a really, really good job at adopting it, using it, and we're seeing it used more and more every day. That's all I have.
John, thank you. We had one question from somebody looking at this photo of the plastic covers in the picture and what you're doing to mitigate. Walk through the intubation or advanced airway, some of the training you guys have been doing here.
Sure. So the bag was an idea of one of our field paramedics. Right when the COVID-19 pandemic started hitting our area, one of our crews was on a cardiac arrest call where the patient was just nonstop vomiting. and she sent me a message saying, hey, wouldn't it be nice if there was some kind of bag that we could place over these patients and kind of shield ourselves from the vomit and everything else that was occurring. So I said, hey, that's a good idea, and then she kind of threw some ideas out of how she would like to see this bag designed. And then about 2 days later, Dr. Jarvis came in and said, hey, we need to create a bag that we can use to kind of shield our crews, especially when we were having a hard time getting viral bacterial filters and PPE was kind of scarce. So we reached back out to that medic and said, hey, give us a prototype. And she did. And so what you see there is one of the prototype bags, but essentially it goes down to about the waist of the patient, drapes over the head. And at a certain point in the rest or a certain point in our DSI process, once the patient has been sedated in DSI, we place the bag over them. And then there's, I don't know if you've seen those big plastic gloves that come up to your elbows that are veterinary gloves, or shoulders that are veterinary gloves. They put 2 sets of those into the bag, and they're secured using Gorilla Tape. And the little red tape piece that you see on the left-hand side of your screen, there is a grommet where the viral bacterial filter will snap into that and attach to the ET tube, and then your BVM and everything else on the outside with additional filters. So we intubate using the King Vision underneath the bag, and you can see through the clear plastic, and you can still see your screen. So this is an additional layer of protection for our crews. It's not mandated that they use it. However, we do have it available to them. So viral bacterial filters, and we call it the Brandy bag for Brandy. She was the medic who designed it. So we have the Brandy bag on every truck. We have some on our commander truck, and then Round Rock Fire Department, who is pictured there in the Frog Top gear, were one of our ALS first responder agencies. They also were interested in the bag, so they created some as well, and they have them on their apparatus, I believe, as well.
Thanks, John.
Did that answer your question?
Yeah, that's great. We're going to transition now into roundtable discussion, starting with, I'll ask a question and then we'll walk through. The question is, going forward, how do you plan to use mobile technology, not just for COVID-19 management, but for also patient care? And we'll start with Colorado Springs.
Thanks, Chris. So we are certainly looking at expanding sort of integration of Pulsara into our pre-hospital medical care. As we work through this concept of tiered response in our community, we certainly look at an avenue where we could leverage the technology straight out of our PCEPs or 911 authority offices to connect a physician with a patient even before we dispatch a unit or a physical response. And then obviously we look at it for follow-up and follow-on care from the emergency department. So a lot of times we'll take care of a patient in our ER, and we will discharge them, and maybe it's a wound or cellulitis or something simple that we just want to look at the next day. The patient app version of Pulsara is a great opportunity to ping the patient, create a quick 10-minute, 15-minute encounter to do some follow-up care. So those are 2 avenues Dr. Bronski and I are kind of exploring and looking at.
And this is Stein Bronski. As we mentioned before, we've been using Pulsara for about 4 years, and we started in a very narrow fashion, just using it for STEMI and stroke. And we have now realized over the last couple of years that the best way to function into the future, regardless of COVID, these conversations happened way before COVID, we needed a system-wide approach to advancing our communication. I think everybody struggles with having all these different modalities and chain links that can break. We see Pulsara as a holistic system of management, system of care solution that we are planning on expanding through the entire patient base, not just isolated to like strokes or heart attacks. And so we're actively already working on that and see that as the vision of our near future.
Great. And there was a question out there that said, how do patients have access to Pulsara from home? Are they registered beforehand? Do people register for Pulsara if they have no medical history? And the answer is Pulsara can only be initiated by the provider. Our biggest concern was having patients always trying to get a hold of their clinicians. So instead, the patient receives a push notification from the provider. The app's downloaded in real time. It's authenticated, and then the telemedicine consult is started by the provider. And it's encrypted, secure, and from start to finish is a simple process, the same as downloading an app from the Google Play Store or Apple App Store, and can take as little as maybe a minute and a half to be up and running. So with our time, I'm going to actually jump to question 2 and have both Chris and John answer this one. Question number 2 is, please share your efforts on mobile integrated health or community paramedicine or any of the other unique programs your organization is completing.
Yeah, so we've been blessed to have a very robust community health paramedic program in our system for quite a few years now, and that program is continuing to grow yearly with more resources and more things that they're doing. They do quite a few things with the homeless community, as well as psychiatric patients or frequent callers, and also just folks that just don't know how to get the information they need, and you might not know how to get in contact with the right resources. So we have a pretty robust program already, and they've been doing a great job of doing this mobile integrated healthcare and working on getting folks to the right resource that they need, because a lot of times that's not an emergency room and they don't need an ambulance. Going forward, I think that some of the benefits that come with Pulsara could really benefit that program, our CHP program as well, and that's something we're looking into going forward, of using it in that as well as for STEMI strokes and things like that coming in the future.
Yeah, here at Williams County, we have a group of community health paramedics that are very interested in using Pulsara. These patients that they see on a regular basis are scattered throughout the county, and they may not be able to hit as many patients driving around from house to house. These are medically frail patients that maybe don't need to be seen in a hospital, and so they can probably reach out to more individuals using Pulsara. They can gauge whether they need to make a drive out to that place, to that patient's residence, and assess them there. But it gives them an additional tool to be able to reach out to this population of patients that we have, and could probably increase their workload without having to drive all over the county in most cases. But that's something they're very interested in doing with Pulsara. I know our Williamson County and Cities Health District is expanding its use as we've had a little bump in COVID positive patients here. And then we also can use it for maybe some alternate sheltering sites as well. So there's a lot of possibilities. We've brainstormed quite a bit of things that we could use, and it's just a matter of implementing those. The more immediate thing that we're doing is we have a core of what we call senior medical officers. And what we're going to be doing with them is we're going to have them use it on all calls, and just to kind of put Pulsara through its paces, and maybe even possibly eliminate a radio report with Pulsara. And we've reached out to all of our hospital partners here in Williamson County, and so far the reception has been very good. They're interested in it, they like it, and they're looking forward to what we're going to be doing with it in the future.
Thank you, guys. It's been super great. We were talking about communications and inefficient communications, and one of the bottom lines that I heard from Stein as he started out is when it becomes a MCI, or the active shooter, the stadium collapse, the bad bus rollover, or you set up a little bit higher to the disaster, the California wildland fires, the earthquake, the tornadoes, the hurricanes, or you even scale up to worldwide pandemic, it's really not the best time to take something off the shelf, dust it off, and start it. Instead, by using something that you use every day that can be scaled up and then scale back down seems to be the most appropriate. And with that, let's move on to AJ. Thank you.
Thank you. We have a couple questions in here. Back on the MCI side, can Pulsara be used to bring up multiple hospitals for information, for example, from a transportation area? Chris, I'll direct that one to you.
Just bear with us for 1 second. Chris is dialing back in. He got disconnected.
Okay. While we're talking then, this is used from a regular phone, right? You don't need a separate communications device, or do you?
That's right. Yep. It's just using mobile technology that everybody already knows how to use in the palm of your hand. So simple and easy to spin up, no proprietary hardware of any kind.
All right. Will any of the data or video images or forms flow into an EPCR platform? Is that one I got to wait for Chris on?
Yeah, it looks like Chris clarify on that one.
Okay.
Yep, and I'm on.
Chris, you're on. Can we use any of the data, video images, or forms and have them flow into an EPCR platform?
Oh, it's a good question. So technically, yes, we do have a public API, which allows us to connect with EPCRs, and we also built the entire system from the ground up at the beginning to be NEMSIS compliant for that opportunity.
Okay. Now we have a question here from Kelly Urban asking about in the pre-hospital environment, how have patients accepted the use of the app consultation via face-to-face response? Has it been favorable, or have had issues with patients refusing this platform?
So this is Dr. Angelitis. I'll field that. By far and away, the most consistent responses are positive. People really appreciate the opportunity to teleconnect with a physician and have a real-time, patient-centered discussion. So I've found it to be very positive.
Yeah, and I'm just going to give you my perspective from AJ here, and that is that the COVID-19 pandemic has opened up the door, I think, for CMS, for reimbursement, for telehealth. So if you're not thinking about telehealth right now, you're going to be light years behind, because I don't think after the pandemic we're ever going to go back. We're going to still do. I have an appointment in 2 hours with an eye doctor over telehealth, so I don't have to go to the eye doctor. I'm going to be interesting to see how she checks my eyes, but other than that, I think that it's here to stay. Do any fire departments have cross-trained as paramedics use Pulsara? I think we're looking for some names for a fire department here who they can contact that use the program that's in the fire department. Certainly Colorado Springs.
Yes, sir. This is Stein Bronski from Colorado Springs. Our fire system is paramedic-based, and so anybody could contact us to talk about that. It has been working smoothly with our paramedics in the fire service since the day we initiated it. One thing I would like to add that has been popping up on the questions is, just how easy is this to use? Well, I'd be embarrassed to tell you that when we first launched Pulsara, we had multiple agencies to train, and the core agency, which was our fire-based medical response, didn't get the training, and we didn't realize it until the morning that we were launching. And within that one day, we were able to disseminate all of this and have the fire department paramedics using the application seamlessly because it's so intuitive and goes along so well with just everyday usage of a smart device.
Yeah, and let me just follow up, and I'm pretty biased because I'm a big fan of Williamson County and of Austin Travis County. If those two magnificent systems are using Pulsara, you can bet that it's been completely vetted because their medical directors are absolute HIPAA and other clinical care. Colorado Springs, the same thing. Wonderful system, ahead of the game. So, Chris, I'm going to ask you to answer number 24. It's pretty detailed about the infrastructure and communication portability.
Yeah, it asks about the infrastructure and communications portability between systems. And really, it's based on mobile technology. And so the focus is, instead of having what big system is at the hospital, what big system is in EMS, well, we use PC-based, we're mobile-based. What we decided to do is say, listen, everybody has the technology they need in the back of their pocket. Let's make it secure. If I can take a photo of my bank check and the bank can deposit that check, if I can, with a couple taps, buy a pair of shoes and watch them be delivered all the way to my house, and of course my bank and my secure information from my bank was transmitted to that. If my mother, who's mid-60s, and my nephew, who's 3, can, without an instruction booklet, connect in real-time video using FaceTime, we should be able to do that in medicine. And we should be able to communicate seamlessly and simply using mobile technology. So it's actually platform agnostic, and there's very little IT lift on the EMS or the hospital side.
Yeah, we had somebody ask if we're going to do a hard stop because it's after 1,300 hours. The answer is no. We're going to go a few more minutes and try and answer as many questions as we have. If you have to drop off, you can see this archived, but we're going to continue for a few more minutes. Question, is there an EMR to Pulsara?
Yeah, and I think what they're asking, is there an EPCR
like a
or EHR or a medical record? There isn't a medical record in that we are not a documentation system, but clearly we do collect data, right? You collect data when you got on scene, you collect data when you're integrating possibly with the heart monitor, you're integrating with that. And yes, we do allow all of that to flow out in a number of different formats. It could be the raw data, and a lot of EMS and hospital systems are looking at the raw data and then using that for their report reconciliation for accreditation or the CARES registry, so on and so forth. People can export as a PDF. And they also have instant visibility. So when the case is closed, what we're seeing is that, for example, the heart attack, the patients bypass the ED, they go in, they get their cath, the case is closed. The physician may take, or the cardiologist or the STEMI coordinator would take a photo of the heart before or after, and then put that into that case. And when they close it, everybody, including the crew on the EMS system, will get instant feedback. And of course, that's all in a database, and it's all in a dashboard so that the administrators at each place can track trends.
Okay, here's a really great question from Nina Hawk about, could Pulsara be used in a domestic situations for law enforcement or in law enforcement?
That is a great question. And the answer is, by securely connecting with the right people at the right time, you can transmit any type of information, right? And so the opportunities in the future to expand in public safety beyond the EMS side for, scene and fire operations, for disaster MCI operations, for law enforcement operations, and emergency operations centers and dispatch. We're actually seeing some of that evolve even naturally with this pandemic.
So realistically, you could transfer over, for example, if you were in a living room and something was going south on a domestic violence call and the police were responding and didn't know what it was, you could technically open up a link so they could hear what was going on through their comm center doing a patch, right?
Yeah, this is one of those where somebody in the medical world says, This is a disclaimer. We're not advising you to use this medication, but it could possibly be used for that. And that's what we're seeing. We're seeing that by bringing in dispatch early and having them added to that patient channel, then we can connect and communicate with anybody. At this point, this has been primarily, and when I say primarily, 100% used in the clinical application, but for a potentially anybody to initiate that call, it's got to be from the provider or the law enforcement person connecting to that person.
Right. A question here, and I could even answer this, is Pulsara and use are available on the East Coast, like the New York tri-state area?
Yeah, AG, are you going to take that one?
I guess, I could tell you guys, I spent $2.5 million when I was in Eastern Pennsylvania putting a system together with microwave links, et cetera, and matrices, and this system in the palm of your hand can do everything that system used to do. So, thank God for Pulsara. I think you could use it anywhere in the U.S., anywhere in the world, actually, but I'm not taking you outside the U.S., but anywhere in the U.S., am I right?
Yeah, so Pulsara is across the U.S. It's on the East Coast, West Coast, North and South, and then we're also being used in Australia.
Okay. There was a question here. How would you implement your system for smaller volunteer agencies that do not have online medical control available 24/7?
Yeah, so Pulsara, and this is a great question, because for Pulsara in rural areas, this is exactly what it allows you to do, right? It doesn't have to be online medical control 24/7. Pulsara 1 is the freemium version of Pulsara. That is free for the EMS services. I say that plural because there may be a number of rural EMS services in your area or fire departments in your area. It's free for EMS. And it's also free to that receiving emergency department. And so what that allows you to do is, in essence, replace the radio report. And so you can use Pulsara not necessarily for your 24/7 medical control if you don't have that in rural areas, but instead the ability to communicate in real time with the community access hospital that you're transporting to at 3 a.m. in the morning.
Yeah, but let me go a little bit deeper. If I was in a rural area, I could contract with somebody. I know a physician, and you know the same physician, who is in the Dallas area, and he handles calls in the Atlanta area by his phone. So you could subcontract with a hospital or a provider physician to do your medical control, and Pulsara could make that link happen.
Yeah, and the new advent of I think one of the mainstays that we're going to see as a takeaway from the coronavirus or COVID-19 pandemic is the acceptance of telemedicine in the pre-hospital environment.
Yep, no question. I think we'll take one last one here. Well, two really. And one is, who pays for this? I'll let you answer that first, and then I'll give you the last question.
Yeah, this is a subscription model. It's a great question. It is paid for by the hospital. So the hospital, if you look at kind of the big idea of EMS, is possibly making one phone call from EMS to the hospital in the normal transport situation. Like I said, Pulsara 1 for EMS transporting to the hospital is free for EMS and the hospital. It's behind the ED door. So those critical calls where they need the entire trauma team, the STEMI team, the sepsis team, the stroke team, it's a complex environment, and so the hospital pays for the service.
Yeah, and it could even be a consortium of hospitals, am I correct?
Oh, absolutely. There's places and states, state consortiums where an entire state is implementing Pulsara across to their hospitals.
And you know, truth be told, I don't get a penny from Pulsara. I'm just saying this out of my knowledge over the years. That this program's been around for a while and has been vetted through many hospitals. So they have total approaches that you can use to get this into your hospital. Once you do a demo with a hospital of all that this does, the hospital is very easy to get on board to help with this, particularly after all of this with the COVID. This is a great time to strike and ask the hospitals to consider bringing this on board. We're going to wrap it up here with the last question, and that's how does Pulsara fit into rural first responder groups with no transport that rely on somebody like AMR for follow-up with advanced care? How does that link happen, Chris?
Yeah, and it's the same concept as the handoff that we do at the hospital. And so Pulsara is set up so that, and what we're really working on this next version is the EMS to EMS handoff. So the first responder or the non-transporting BLS, emergency responders, or even paramedics that are non-transporting can start the case and then transfer that to the ALS transporting agency and or flight teams. And it's really the same concept of the community access hospital starting a case and then being able to transfer that case to a larger hospital.
Good. I think we're going to probably wrap it up. I want to tell you that I'm going to invite each of the participants today that come on something new that we have on GEMS called My EMS Today Show, kind of a spinoff of the NBC Today Show, but I don't have Savannah Guthrie or Hoda Coffee. I have my two therapy dogs, Charlie and Cooper. So if you go on to GEMS.com and click, you'll see some very interesting shows that we've had so far. The other day, the Sacramento area was on. Within a week, they put up a community care, community paramedicine program to attack the nursing home areas, and they've impacted 300 patients so far. So a lot of interesting things that I'm trying to do on there. Something like, oh, I wish I could write about that. I'm not writing about it. I'm talking about it. So, on behalf of GEMS, Clarion UX, I'd like to thank all of our speakers today and certainly our sponsor, Pulsara, for today's presentations. How EMS leaders are using mobile technology to manage the COVID-19 crisis and beyond. And as you heard, this is not just a pandemic software. It's something that we bring to your attention, but it's been around for a while and it's going to be around. And in almost anything you can imagine linking with your cell phone, you can probably do. We're going to archive this within 24 hours. It'll be accessed from our homepage at GEMS.com. A reminder email message will be sent to all of you, complete with a direct link to the archive. Stay on for a bit when we close, and you'll get your certificate. And as we said, you can download a PDF and a special case study. And we certainly thank you for joining us today and look forward to serving you with more webcasts in the future. Stay safe.